CVS Part 1 Case 15.
A 56-year-old man presents with an 8 months history of progressive dyspnea, orthopnea, fatigue and reduced exercise tolerance. He also reports occasional palpitations, intermittent vague chest discomfort without typical exertional angina. He medically history is significant for poorly controlled hypertension, type 2 diabetes, long-standing heavy alcohol use. He recalls a febrile viral illness with myalgias and pleuritic chest pain approximately 2 years ago, after which his exercise capacity gradually declined. Examination findings includes blood pressure is 102/66, heart rate is 108, respiratory rate 20, oxygen saturation is 95% on room air, elevated JVP, bibasilar crackles, laterally displaced diffuse apical impulse, S3 gallop, mild hepatomegaly and biatrial pitting edema. ECG shows sinus tachycardia, left bundle branch block, non-specific ST changes, and labs include markedly elevated BNP, high sensitivity troponin I, persistently elevated without dynamic rise or fall, mildly elevated creatinine. Echo findings includes dilated left ventricle, severe global hypokinesis, EF is 24%, mild functional MR. Coronary angiography reveals non-obstructive coronary arteries. Cardiac MRI pattern shows markedly dilated LV with severe systolic dysfunction, patchy mid-wall LGE, no subendocardial or transmural scar in a coronary distribution, no edema suggestive of acute infarction. Which of the following is the most likely interpretation of the troponin elevation and MRI findings? Option A. Troponin elevation proves silent myocardial infarction indicating ischemic cardiomyopathy. Option B. Troponin elevation is due to chronic myocardial injury and MRI supports non-ischemic cardiomyopathy. Option C. Troponin elevation excludes non-ischemic cardiomyopathy and is specific for plaque rupture. Option D. Troponin elevation is due to pulmonary embolism and MRI findings are incidental. Option E. Troponin elevation in heart failure always indicates acute coronary syndrome requiring revascularization.
This is a case of non-ischemic dilated cardiomyopathy. Now, what are the 4 key features which help us in diagnosing a non-ischemic dilated cardiomyopathy in this case? First one is the echocardiographic finding, which signifies global left ventricular dysfunction. Now coming to the second point, the cardiac MRI finding. The cardiac MRI finding here is specific for non-ischemic dilated cardiomyopathy, which is mid-wall patchy late gadolinium enhancement without any subendocardial scar or a transmural scar in the coronary distribution, which otherwise we can find in ischemic cardiomyopathy. Now coming to the third point, the persistent elevation of troponin I reveals chronic myocardial injury and it signifies non-ischemic cardiomyopathy. Again, in ischemic cardiomyopathy, we will get a dynamic rise and fall of troponin I, where it rises steeply and then falls steeply as well. A non-obstructive, this is the fourth point, that a non-obstructive coronary angiography tells us that it's not a ischemic cardiomyopathy and it's a non-ischemic cardiomyopathy. Now, what are the 2 take-home main messages here which all the students should know, which are the high yield golden points for the exam? The first point is that a specific cardiac MRI pattern of mid-wall patchy LGE is pathognomonic for diagnosing non-ischemic cardiomyopathy. And second is a persistent elevated level of troponin I tells us that there is chronic myocardial injury and it is not a steep rise and a steep fall, which otherwise indicates ischemic cardiomyopathy. Now coming to the option exclusion. What is option A?
Option A is troponin elevation proves silent myocardial infarction indicating ischemic cardiomyopathy.
So always troponin elevation does not indicate a silent MI and acute myocardial infarction. Here it is persistently elevated, which signifies non-ischemic cardiomyopathy.
Option B, troponin elevation is due to chronic myocardial injury and MRI supports non-ischemic cardiomyopathy.
This is the correct option as discussed. The persistent elevated troponin I and the cardiac MRI specific pattern reveals that this is a non-ischemic cardiomyopathy.
Option C is troponin elevation excludes non-ischemic cardiomyopathy and is specific for block rupture.
This troponin I elevation is not specific for clot rupture.
Option D is troponin elevation is due to pulmonary embolism and MRI findings are incidental.
Yeah. So this is also again wrong because it's not the elevated troponin I levels are not indicative of thromboembolism.
Option E is troponin elevation in heart failure always indicates acute coronary syndrome requiring revascularization.
This is again a grossly wrong option because a persistently elevated troponin I level does not always indicates acute coronary syndrome requiring revascularization. On the contrary, the persistent elevated troponin I levels indicate non-ischemic cardiomyopathy and its management algorithm. Thank you.
Search Edumedex on Instagram and YouTube to start your journey today.